AFOMP School webinar. So once again, welcome to this 21st monthly webinar of the AFOMP. And actually, Dr. Seen from Australia was to give a talk, but unfortunately he took ill just yesterday, and because of inability of his joining, we immediately arranged another talk. And now today it will be role of medical physics in precision radiation oncology, and it will be given by Dr. V. Subramani, and he was to be actually moderating the session, but now he will talk about this very interesting topic of medical physics role into the precision radiation oncology, and I will be moderating these things. I will just introduce Dr. V. Subramani, who is Assistant Professor and Chief Medical Physicist at the Department of Radiation Oncology, All India Institute of Medical Sciences, a premier institution of India, and they have National Cancer Institute. He has over 26 years of experience after doing his master's in medical physics and doing PhD from AIMS. His research focus is on medical aspects of radiation oncology for cancer treatment, IMRT, IGRT, SBRT, 4D adaptive RT, and image-guided brachytherapy. That is a recent development which are going and happening into the radiotherapy field. He has been awarded and received many honors. To name few, UICC fellowship in 2002 to go to McGill University, Canada, PhD examiner for various universities, more than 100 publications and presentations, IOMP scientific committee, the member, then editor of the Asia Oceania Federation AFOMP's newsletter, and he's also Secretary of Association of Medical Physics of India in a second term. With this brief introduction, I invite Dr. V. Subramani for delivering his talk about the role of medical physicist into the precision radiation oncology. Now the floor is yours, Dr. Subramani.
Thank you very much, sir.
You can share PPT.
Yeah.
Yes.
Hope.
Yeah. It's audible. Just go to the PPT mode. Yeah, go.
Okay.
Go.
Thank you very much, Professor Arun sir, for kind introduction. Good morning, good afternoon, and good evening to everyone, whoever, wherever you are. As you rightly said, today it's a kind of contingency plan. I have been asked to deliver yesterday the topic, which is almost similar what he has proposed to talk. The earlier talk was on functional alignment to the anatomical alignment of radiation oncology medical physics services. And I thought, okay, and by taking in and understanding the topic, I thought, okay, let me put it in this way, that, what is the role of medical physics in precision radiation oncology? So this is what I would be, talking for another 35 to 40 minutes. So in my talk, I'll give an introductory, the kind of the overview about the role of medical physics in radiation oncology and what are the milestones in radiation oncology practice we have reached as of today. What is the current status in precision radiation oncology and current radiation oncology physics research? What are the challenges and opportunities? Future directions in practice and the research in precision radiation oncology physics, and summary and conclusions I'll deliver. So to give a brief introductions, as we all are medical physics audience, not necessary to give much about what is medical physics or what is radiation oncology. However, to just briefly give a perspective about introductions, radiation is the most effective the organ sparing treatment for cancer, in addition to the surgery and chemotherapy, and also other the recent the treatment modalities. The radiation oncology is basically a system-based medicine. Basically, this is driven by the physical sciences and technology, having interdisciplinary team of radiation oncology and medical physics and radiotherapy technologists. So more than 50% of cancer patients requires radiation treatment during their course of illness. And the safety first approach is very much essential in radiation therapy, because it is a double-edged sword. The patient's treatment outcome that depends upon the dose delivery accuracy and precision. So that means the precision inherently is being practiced in radiation oncology. However, that what is advancement in precision, that is what we are going to see. So the patient's treatment outcome in conventional radiotherapy depends upon the prescription dose, if varies plus minus 5%, whereas in high precision radiation therapy, if there is a geometric variation in the beam shaping device, just for the example. So if it is 1 mm, the variations could lead to the 10% of dose variation, which will be very significant in terms of the patient's treatment outcome. So according to the WHO and IEA 2000 reports, based on that an analysis of the incidents and accidents, they concluded that the erroneous radiation treatment and accidents are more prone due to the technical factors involved than the clinical work. So that was the reason. And one of the main goal of our role of medical physics is to ensure the radiation safety to the patients and staff and public, and also to improve the quality of the patient's treatment, in turn the patient's treatment outcome. So this is what actually in general the medical physics as a clinical partner they have the role to play. So coming to this, the major milestones in radiation oncology, I'm not going to go into the detail, but certainly would like to give that kind of overview. Soon after the discovery of X-rays, the low energy KV X-ray beam started in the radiation treatment practice, following radium-based and cobalt-based radionuclide therapy, then high energy MV X-ray beam with electron beam, and 1980s and the stereotactic radiosurgery and in the proton therapy. So these are all up to 90s. You can see that kind of the radiation being used for cancer treatment. So very important to understand and know that the latest developments in 2000 onwards, which was really the revolutionized radiation oncology practice after the introduction of multi-leaf collimator and electronic portal imaging device, cone beam CT for IGRT, and ring gantry for image guided and IMRT, robotic LINAC, including the 4D motion management technologies. So these are all the currently in practice. Most of the centers, though the 3D conformal radiation therapy is the standard of the care, but most of the centers globally, the advanced strength centers, they do practice with this kind of the technologies and techniques. As we are in 2020s, the emerging practice in radiation oncology is evolving in 3 major areas. One is an adaptive radiotherapy, that is real-time or online table adaptive radiotherapy. And also the biology-guided radiation therapy. Say, for example, the PET linear accelerator also started, being in the practice of now radiation. So the biology-guided radiotherapy is also possible, and thereby the precision radiation oncology is evolving and emerging practice as of today. So there are 2 ways of classifying the precision radiation oncology. One is the technology driven the precision radiation oncology, like what we are practicing with the technologies like linear accelerator and other conventional devices. And another one is that biology guided biology driven precision radiation oncology. So this is what I'm going to focus on it. And the brachytherapy, for the sake of completion, the brachytherapy started from radium source to that, today the MR guided, image guided adaptive radiotherapy is being practiced. So, in radiation oncology, so there are a lot of technologies are available, but to just briefly give the overview about what the technologies today is in the development of IMRT and VMAT and radiosurgery and SBRT. So these are the technologies are being practiced globally. And also in the case of the particle radiotherapy, ranging from multi-room proton therapy to the single room compact proton therapy system. Also in certain places like MedAston, there are the dual particle therapy system also is available for patients treatment. And the latest the technology emerging is the MR linear accelerator and AI-based linear accelerator and PET-LINAC. These are that the technology-driven the precision radiation oncology we practice. So what we have achieved out of this technology-based the radiation oncology practice is that the simulation imaging also started from 3D to 4D and also MR simulation. And the deformable registration also an advanced, for IGRT and 4D adaptive treatment planning from 2D to 3D and 4D and biology-based, the multi-criteria and the LET-based auto planning with the Monte Carlo GPU-based advancement has taken place. Similarly, in the treatment delivery, IMRT and the VMAT, which improves that the delivery efficiency and patient throughput. IGRT corrects for the position of the patients and target and OIR errors and reduce that margin. The stereotactic radiosurgery and SBRT with the frame and the frameless hyperfractionations will be useful for dose escalation and hyperfractionation, and triple high dose rate dose delivery will result in a fast dose delivery and reduce the tumor and organ motions in delivery. 4D radiotherapy accounts for respiratory motion effects in RT process. Adaptive radiotherapy accounts for volume and dose changes and modify the treatment plan when it is necessary. Particle therapy is, the better treatment options for pediatric and radio-resistant tumors. So these are all that, the above all the technological, the advances or benefits which we are using everyday practice now. And now the emerging practice is MR-guided radiotherapy and bed-guided radiotherapy towards biology-guided or precision radiation therapy. That is what we are going to look at it. So if you look at that, the briefly that, how the technology and outcomes starting from the 2D, there is a phenomenal increment. Then after that IMRT, there is a slowly, the increment, and then, carbon ion, there is a small, the plateau regions, which we are actually, able to achieve the precision in the physical conformations using that carbon ion and proton therapy. However, so the limitation is that there are still, the survival of the patients or the treatment, the outcome is not so the significant compared to that what has been earlier. Although it is, the toxicity and, the organ sparing and quality life has been increased. So that's the limitation of this technology-driven, the radiation oncology, precision radiation oncology. Coming to this, the concept of precision medicine. You all are aware, indeed, the Institute of Physics has initiated the concept of, the precision medicine. However, that, the revolving 4 important points like the predictive, preventive, and personalized and participations. You predict the disease before it occurs. You prevent the disease before it advances and personalize the treatment to a particular patient specific. And participation of the stakeholders, including patients and the providers and governments, everyone has to participate that the how to improve that the treatment or the service of the medicine or precision medicine. This is what that the goal revolving that 4 P's. So if you see that the conventional medicine, the major difference is that the treatment is based on that the histopathology and based on the TNM staging. The having the informations, like one size fit for all, based on the anatomical sites and TNM stage and histological grade and risk profiles and the clinical features. So then the result of the treatment will be maybe some of the patients will respond to the treatment, some of the patients may not be responding to the treatment. So this is what the population-based treatment. So in case of the precision medicine, if you look at that, the individual patients, the treatment can be designed based on that the genomic and omic level. And also based on that, the behavior of the particular patients are, they're taking that the parameter into the account, like the health history and medical records, and even including environmental parameters, etc. So if you consider or you incorporate these kind of, the specific the parameters into the treatment planning or, treatment, you can customize the treatment based on that, the particular patient's, the individual information. So whereby you will be able to customize or personalize the treatment, and each patient will benefit from that, the customized treatment. That is what, it is that the future of the medicine, or indeed the precision medicine is. So what is the need for the precision medicine in radiation oncology? The current practice, they rely upon, as I told, that, one size fit all. That means population-based clinical factors such as, age and stage and gender. So that is basically in a patient A specific with a suboptimal outcome. So the outcome is compromised basically. Because of the advances in medical imaging and biotechnology, or indeed the omic technology, so there is a tremendous growth in patient-specific information from anatomical to functional to molecular and biological profiles of individual patients. The information about the genomics, which provides the each and every patients to guide the personalized treatment, is the basic principles towards the precision radiation oncology. So the success of the treatment depends on the ability to choose the right treatment regimen, that means the precision, for the right patients, that means the personalized. So the interchangeably people call it as a precision medicine or personalized medicine. So it can be called as a precision radiation oncology in general. So this precision medicine approach, how it applies to that, the radiation oncology practice. So if you look at that, kind of the conventional way of designing the treatment is purely based on that, the classic clinical and pathologic features such as patient's age and comorbidities, tumor stage and location and histology, etc. But when you want to really design that, the precision radiation oncology, the additional information such as, the tumor molecular features, like in the genomics, the features such as the mutational status, whether it is oncogene or tumor suppressor gene, plays the mutational, the driving, the mutational driver, and the mutational burden. Then the copy number alteration, whether it is insertion, deletion, and translation, or the gene expression patterns, what kind of the gene expression patterns for the particular, the patient, or the protein expressions and pathways activities. All these informations can be incorporated into the treatment design, which will give that, the more, the customized treatment. Not only that, in addition to that, tumor imaging features, like the radiomics is important to use for use in the precision radiation oncology, which will define that size and location and shape and heterogeneity of the tumor. Indeed, it's like in the virtual the biopsy kind of the role it will play. And in addition to that, the tumor functional profiling such as XYO assays and patients derived the models, including cell lines and organoids and xenografts, etc. So all these, the parameters will be the helpful in deciding, the treatment. That means who requires the radiation, who can avoid the radiation. So what is the appropriate radiation dose and field, and which agent should be combined with the radiation? What is the optimal sequence of therapy? Say, for example, if your patient wants to, need to go to that, the different, the sequence of therapy, like, the radiation, chemo and surgery, and, the hormone or immuno, then what could be that optimal sequence of therapy is possible? Based on these informations, one can design that precision radiation oncology. So what is that actually the precision medicine or the precision radiation oncology requirements? So indeed, as I initially told, the precision radiation oncology can be classified broadly in two ways, like technology-driven precision radiation oncology and biology-driven precision radiation oncology. In technology-driven precision radiation oncology, like the IMRT and SRS, SRT, 4D, and all that, the physical image-based, the physical image-based, the radiation confirmation is, the technology-driven precision radiation. When it comes to that, the biology-driven precision radiation oncology, so there are important, the components are required, like the quantitative imaging. If you know that, the evolution of the imaging in radiotherapy also started from the 2D to 3D and 4D and then the hybrid imaging like a PET CT, PET MR. Now it is coming to that quantitative imaging, and also it's called in quantitative imaging biomarkers. So there are different, the methodologies or the terminologies being used for quantitative imaging biomarkers, such as, the radiomics, genomics, and radiogenomics. So this is one of that important additional, the information or the technologies being utilized for incorporating this, or designing the precision biology-driven precision radiation oncology practice. And everybody today, the advancement in adaptive radiotherapy is towards the real-time adaptive online on-table adaptive radiotherapy is possible with MR-guided radiotherapy systems such as MR linear accelerator. As of today, there are 2 vendors commercially available for the clinical practice, which will be briefly talked about in the later slides. And also that, the PET-guided radiotherapy using the PET linac and MR-guided proton is not yet practiced, but definitely it's going to be in the future, and it is in the in the investigational or the technology development process. And in 2016, the National Cancer Institute US, along with the ASTRO and the AAPM, they have conducted the workshop on the precision medicine and genomically guided radiotherapy, how to design. So that is one of the important concepts now evolving in radiation oncology to incorporate or to practice the biology driven precision medicine. And the another important tool is required for the precision medicine is artificial intelligence, because when you are going to have lots of informations, it is required to have the automations using that the machine learning and deep learning methods. And when you are going to have large amount of data which is not possible to handle by conventional methods, so the methods like big data, the methodology or data science is required to the data sharing and data the mining. So these are all that the important the components to practice the precision medicine radiation oncology. So coming to this, the quantitative imaging biomarkers. The biomarkers basically are an objective and the quantifiable characteristics of the biological process. Basically, it's a surrogate which indicate that what kind of the biological process are taking place inside that the particular environment. So it will quantify the individual tumor biology, and also it will give that information regarding the heterogeneity or intratumoral the heterogeneity information, and also it can give you that in the tumor microenvironment information surrounding the tumor. And this will be useful not only for the before volume effect, it can be useful to understand that when it comes to that the physiological effect time itself. So, and also the quantitative imaging biomarker is more useful in response assessment. You will be able to assess that the treatment response is actually the positive or the positive outcome or not. Accordingly, you can adapt the treatment when it is required. So the quantitative imaging biomarkers is an important component to design that the precision radiation oncology, and these are the roles. So what are the properties? An ideal biomarker should be a specific to a particular biological process. It should be sensitive enough to predict that what kind of the biological process or what kind of the signal has taken place, and also should be a predictive. It should be a stable, and it should be a non-invasive, so that it will be easy to make use of the everyday the clinical practice. So the clinical application of the quantitative imaging biomarkers ranging from the diagnosis to staging and patient stratification or patient selection, and then treatment monitoring, and also the outcome predictions and risk assessment. So these are all in the general the kind of the overview about the quantitative imaging. As I told you, for the example, the quantitative MR imaging will be more useful to quantify not only that the anatomical or morphological informations in designing or delineating the target or the target definition. It is also possible, or it is useful to quantify the individual tumor microenvironment informations having the functional and molecular imaging. Say, for example, the cancer of cervix, if you plan with the simple T2 MR images, you will see that the contouring is different when compared to that the functional imaging like such as the ADC and dyes and K-trans and FTG of the PET, then that the original versus modified the GTV and the HRCTV will be different. So this is very much important to reduce that the variations of the target delineations, which is basically a systematic error in designing that the treatment, which is useful in reducing the variations by this. So I'm sure that every one of you are aware that the American Association of Physicists in Medicine task group 294 have come up and recently, especially for the MRI imaging biomarker in radiation oncology. So the MRI is going to really give lots of information, not only the morphological and the functional and the biological and molecular informations, varying different sites. You will be able to obtain that information in a vascular and flow information and physiology and functional information and molecular, including that the metabolism. So these are all the kind of the quantitative MR imaging biomarker is useful in designing that the precision radiation oncology biology based. So what are those informations you will be able to obtain? That the biological the information of the tumor, such as the perfusion and hypoxia, angiogenesis. So all are possible to derive in a different quantitative imaging biomarkers, such as the dynamic contrast enhanced, which will be useful to detect microvascular permeability, blood perfusion, volume fractionation in that blood plasma, and this one ES. Similarly, that the DSC and ASL and BOLD and TOLD, there are variety of the quantitative imaging biomarkers are available. It's possible with the MR imaging the system, which will give you that the kind of the information based on that cellular density, proliferation, and tissue microstructure, and even the metabolism. So these are all the very important parameters to understand a particular tumor behavior in terms of biology and molecularly or genomically. So that information will be incorporated into the treatment design. That becomes the biology driven precision radiation oncology. So coming to this, the MR image guided radiotherapy is an important component of the precision radiation oncology. As we all know that MR imaging is very much important, and it will be useful to give that soft tissue visualization. And also it is possible to give a real-time 2D and 3D imaging. Even for 4D imaging is started, the coming up with the MR Linac nowadays. And the advantage is that, there is no imaging like, the CT ionizing radiation dose is not possible, not necessary, it's not encountered. And the freedom of imaging at any point of the time, there is no concern of the imaging dose. So not only that, in addition to that, the soft tissue visualization, the quantitative informations what have been shown in the previous slides are possible with the MR linear accelerator in the coming days. And although there are the basic the functional imaging biomarkers are available with the existing commercial. You all are aware about that the MR guided RT systems are available commercially. Started the V-Ray, the MRDN from the Cobalt to that in the linear accelerator having 0.35 Tesla MR. And now that the Electa, the Meridian is having 0.35 Tesla, and high field magnetic strength MR like 1.5 Tesla with Electa unit is also available for MR guided radiotherapy. So you can see here, they're having that kind of the different functional imaging of biomarkers is going to give lots of information pertaining to the biology, which will be able to design that biology guided precision radiation therapy. There are other the expanding indications, say for example like the soft tissue abdominal based like liver, kidney, and the pancreas. So the additional the expansion of an indication is possible having this kind of the latest the MR guided linear accelerator systems. I'm sure every one of you have aware about this the PET-CT linear accelerator from the Reflection company from the California. Recently they have got even FDA for the biology guided as well. That the PET guided linear accelerator or the radiotherapy system will be useful in incorporating the tumor biology and the tumor metabolism informations. And not only that early stage, and also in advanced stage metastatic or oligometastatic cancer is possible to treat with this kind of the technology. And you can treat that, the multiple metastatic cancer in single session. No need to, go for a different, the fractions or a different, the time point. So in one go, the multiple metastasis is possible to treat in this kind of the system. There is no fiducial, there is no gating system, and real-time tumor tracking based on the biology is possible. It has the potential for immunotherapy, radio immunotherapy, and basically, it is going to be a kind of biology modulated radiotherapy. This, the system is very potential. And this close not only that, the offline and online, it also closes the loop of, the real time with the biology, the information's feedback system, which is going to give an adaptive radiotherapy more biology, adaptive radiotherapy more impactful in clinical outcome. So coming to this, the radiomics, this is also one of the important component. Basically, radiomics converts medical images into high dimensional quantitative features, which analyzes, combined features with other patient data to provide clinical decision support system. And it is applicable, useful in evaluating the tumor prognosis or predictive abilities or stratification of the tumor histology or stages. It is possible to describe the relation between the images and clinical outcomes, and it has an association with underlying the gene expression pattern if it is the genomic data is incorporated. So advantages is non-invasive, individualized, low cost, and potentially routine procedures, and possible lots of there are a lot of functional CT and MR imaging is possible to have that, the radiomics. And however, the limitation is that genomic information is not possible. That is one of the things. So another important concept is called, the radiogenomics. The radiogenomics, basically the study of a genetic variation associated with the response to radiation. So the radiogenomics, also known as, the radiation genomics or imaging genomics, also known as radiogenomics. The radiogenomics refers to that, the relationship between the imaging characteristics of the disease. That means the imaging of phenotype or radio phenotype and its gene expression patterns and gene mutations, other genome-related characteristics. That is what it is referred as a radiogenomics. Basically, it is a combination of radiomics and genomics, which is also known as imaging genomics. The quantitative imaging biomarker also is, another in the broad perspective, broader name, the quantitative imaging biomarker, which is useful to assess that response to therapy. Basically, in 2002, the Anderson introduced the term, the analogy to the pharmacogenomics. And similar to that, in 2005, West et al. And 2006, Benson Soren et al. Studied about the concept. And in 2009, there is an important development called, the International Radiogenomics Consortium was formed actually under the NCI US. Now there are more than 100 institutions around 20 to 30 countries, more than 200, and the participations are in the consortium. They are collecting the data for various tumors, and there are the European project called the Requite, which is very much the highly the funded project is collecting the genomic data. Similar to that, the cancer genomic atlas data, common data from that NCA US. So basically, it is a radiogenomics towards the translational research, towards the precision and personalized radiotherapy. So what is the genomic guided radiotherapy? So basically, genomic guided radiotherapy, wherein that the tumor incorporating the information about the tumor molecular or genetic information into the RT process called genomically guided radiotherapy. That means, the molecularly, are genetically defined informations for particular each individual patients. And based on that, say for example, if a group of patients is, if you are giving that the radiation, the dose will be limited because of that, the few patients will be having the sensitivity. But if you test that, the genomic, the test, which will give you that what is the patient's group will have that radio sensitivity based on that, the single nucleated polymorphism profile, that SNP. So based on this test, you will be able to the stratify that the high genetic the genetic risk for adverse effects or low genetic risk for adverse effect. A different kind of the group you can stratify. In case if you find that it is the high risk the adverse effects, you may not even consider for the radiation radiation treatment, or you can make an active surveillance, what is happening you can see, and it can be modified the radiation dose parameters accordingly. Similarly, if you come across that the low risk adverse effects, the patients, you can give the standard of radiotherapy, possibly you can escalate the dose. So if you look at that, if you stratify based on that the genomic parameters, okay, you can increase the dose more for the radio resistant tumors, you can reduce the dose for the more sensitive the tumors. So this is what there are important the parameters called radiation sensitivity index and proliferation saturation index. This can be calculated from this the SNP or genomic parameters, and this will be useful to design that the genomically adjusted radiation dose, that's called GOD. So basically the individualized prescription, personalized prescription is possible by means of having that the genetic, and you can see that the high risk the NTCP versus the dose, you can see that the high risk SNP profile and low risk SNP profile. This is what on all the patients, when you don't have that genetic information to design that the radiation treatment. So this is what the genomic radiation is more useful to customize or you to personalize in a particular radiation the treatment. Coming to this, what is that additional that the technology or the information is required from that the existing the standard practice? There is a the latest technology called next generation sequencing technology, which will give the multi-omic platform ranging from genomics to transcriptomics, proteomics, and epigenomics and pharmacogenomics, based on the different molecular classifications, based on which you will be able to obtain that the different information based on the mutational the status and the copy number variation, or based on that mRNA and the mRNA expression, based on the protein expressions and functional status, based on the DNA methylation, based on the individual genetic makeup. So there are various the genetic variation parameters is possible to incorporate into this. So as I told you, there are different techniques and technologies are being used. So these are that the molecular alteration in cancer DNA and RNA informations is possible to derive from this technology. There are emerging technology like the next sequencing technology is possible. There are two ways, two methodology is possible to derive that information based on the genetic variation. One is that called the candidate gene. Another one is called the genome-wide association study, GWAS. So the genome-wide association studies is an important, are more advanced study which will be possible to identify that what is that the SNP, that the single nucleotide polymorphism in a particular the genetic the variant parameter is possible to derive it. So this is what the precision. In order to design the precision medicine, you can derive the parameters from the gene and from the genomics, from the transcriptomics, from proteomics and metabolomics. You can all this information can be integrated into the molecular imaging such as CT and MR and PET, and finally you will be able to derive that the precision medicine informations, which will be called as a precision radiation oncology. So the radiogenomics models in radiation oncology is useful for the biomarkers, useful for decision making, the normal tissue radiosensitivity, which will improve the treatment planning, and the genomic basis for the radiosensitivity is possible based on the SNP analysis. There are two ways, as I told you, the candidate gene and the genome wide association, and there are other parameters beyond that SNP also need to be considered. So when it comes to that, the tumor radiosensitivity, the gene expression to predict the radiotherapy benefit, and prognostic and predictive radiation signatures also possible using these models. So you can see that the workflow that both combined the radiomics and the radiogenomics workflow. So you can see that the different the functional imaging parameters such as the multiparametric MRI prostate and DW1 and the ADC and the DICE. So these are all the different functional imaging is possible to derive that informations, and based on which you will be able to segment the images. Then you can design and you can extract that informations within that the intra-tumor heterogeneity information in terms of the histogram, in terms of texture analysis, and there are a different kind of the methodology is possible to derive that the tumor information or tumor microenvironmental information that will be integrated into the clinical parameter and geometric the genomic or proteome or metabolic parameters that will result in kind of a model. So you can design that model. That model will be useful in predicting the radio sensitivity or radio resistance, and that will be kind of the data, the mining is possible to, make that, what is the important parameters. Similarly, that the precision radiotherapy for lung cancer is, say for example, you see that, if you want to design that precision radiation oncology, there are a variety of the parameters are required, and radiomics parameters, using that CT and PET, even the dosiomics. That means you can derive that information from the dosimetric, the dose distributions. So this is new concept is actually emerging, and all these informations will improve that, the treatment outcome and reduce the, toxicity. So coming to this, I'm not going to go into the detail, and artificial intelligence in radiation oncology is involved from that, the patient consultation to the following follow-up the process, and it is enhancing that, or improving that, automation of the process of radiation oncology. And the big data, yes, because of we are using the different volume and variety and various the data, and the conventional way of predicting, or the data is not possible, methodology is not possible to analyze that in information. It requires a very special the methodology called big data. So various informations can be incorporated to predict and personalize the treatment. So coming to this, radiation oncology physics research, or indeed the physics research. So if you know that, this is based on that, the courtesy of Dr. Rakmeki, and the information is based on US NCI sheer data. So if you see that, 100% of diagnosed with a cancer is coming, out of this 100% diagnosed patients, 70% have local regional disease on the presentation, and 30% have metastatic disease. Out of this 70% local regional disease presentation, 35% are treated with radiation or plus minus other treatment modality. 35% is treated without radiation. Out of this 35% treated with radiation, 25% is achieving the local regional control, whereas 10% fails with the local regional or recurrences and metastasis. Out of this 10% fail with the local regional recurrences, 5% is due to physical cause, the 5% due to biological cause. This is for, simple example. This data is actually pertaining to the US, whereas country like ours, maybe 70% may become a 40% and 30% may become 60%. So it has to be analyzed based on that country specific, the need requirement. So a country like ours, 5% of the physical or biological data is a huge number. So that means we have an ample opportunity to understand how that the physical parameters can be increased to achieve that the local regional control, and how that biological causes can be improved. So this is what. So we are being a medical physicist in radiation oncology department. Always we would like to have what is the clinical problem to address. That is what the problem solving. If you look at that, the recent in 2019 Astro has made the research agenda based on the 6 parameters. Number 1, the normal tissue and reducing side effects, one of the component of the major research. Then the imaging, innovative technologies and expanded indications, the second component. The biomarkers, radiation and cancer genome, the third. And fourth one, tumor microenvironment combination of therapies, and big data analysis and artificial intelligence, the patient's reported outcome, and the health services researchers. So if you look at that, all these components almost related are linked with the precision radiation oncology. This is what the current and emerging. So according to the NCA as well as the German cancer data, so the current medical physics research is in various the directions. The mainly the 23% of radiation oncology medical physics the research is in that implementation and auditing process, and then 17% in the image analysis, and 10% in treatment planning applications, 9% dose measurement and calculations, and the CT imaging, and different, you can see that in the different area of research. So what is that, the future? I'll be, the completing in few minutes. So the medical physics in cancer research. So in the recent publication from Australian journal, you can see that the medical physics not only in the treatment involvement, and also there is a lot of potential in the cancer research, to understanding that how that nature of the cancer progresses, like metastasis and physics of metastasis and tumorigenesis, and what is the difference between the physical characteristics and the cancer. and biology and treatment, personalization, data analytics, and the diagnosis and miscellaneous like the application of new material. All this, the very important the emerging areas are opportunities to do the medical physics research. So this is what grand challenges of radiation oncology, which has been published or they're endorsed by the ISRO, the physics committee. There are 4 different areas. The target definition is to be transformed from the art to the science. That means a model-based, the designing the CTV is possible and needs to be worked out, and development and implementation of artificial intelligence in the clinic and modeling the biological effects towards the personalized medicine is one of the important component of this. The challenges in facing by the radiation oncologists for the future practice, of course, the visionary leadership. So what are the challenges in precision radiation oncology? The reproducibility of the radiomics and radiogenomics are genomic features, and tumor heterogeneity is still, it's not consistent. Need for multidisciplinary and multi-omic integration systems in the clinical practice. Quality control of all this technology is not that easy. So what is it actually the future directions in medical physics or radiation oncology medical physics is? So there are emerging, the practice and expanding roles like the biology guided, wherein the biological imaging, quantitative imaging, and MR and PET MR proton and the linear accelerated proton systems are possible or is going to be the future. And similarly, the genomically guided radiotherapy also will play a major role, having the radiogenomics. And having all this information, of the data, you will be able to guide, that is called knowledge-based or knowledge-guided radiotherapy using AI and big data. And of course, the flash radiotherapy is coming in the big way. We're having all this modality like electron, photon, and proton, and these are the emerging, the technologies going to be in the practice. Now, the radiation oncology practice, not only in radiation oncology based, you will have to really understand what is, the important or, the synergistic effect, when it is going to deliver give the treatment based on the molecularly targeted or, the targeted radionuclide based therapy, radioimmunotherapy, nanoparticle mediated therapy, photodynamic therapy, thermal oncology, including the direct patient's consultation. That is what, the AFOMP 3 medical physics 3.0. So these are all, the clinical practice. Now, not only the radiation oncologists, when it comes to that, kind of the practice in the future, it can be called as an oncology medical physics. And similarly, the research direction is translational research is in, the emerging and technology, in addition to the technology development. I'm sure they all are aware that, the NIH, the NCI has created the physical sciences oncology like in a contemporary, based on the physics of the cancer, and the research, the potential is very much in cancer research, not only the translational or technology development. So coming to this summary, the medical physics is a basic, not only the basic and applied, it is basically a translational science. As a medical physicist, we are responsible for the safety and precision will bring innovations into the clinic. So we optimize and adapt and personalizing radiation for the cancer treatment. The radiation oncology team needs to embrace and adapt to the changes and integrate the radiation, imaging, genomic, and AI technologies and data sciences into the clinical practice. With AI, especially deep learning, more complex models combining multiple data sources could overcome many challenges that stands between research and clinical implementation, especially in the field of radiogenomics. The future of radiation oncology or medical physics is so bright, which is from evidence-based medicine to the precision medicine for personalized treatment towards 4 P's of medicine. The future, we have to be prepared for the future generations to, meet the challenges of today or, the tomorrow, having that, the workforce towards the digital oncology requirements of the future radiation oncology medical physics. With this, I thank you very much and everyone for your, the patience listening.
Thank you, Dr. Subramani, for an excellent talk on role of medical physicist in precision radiation oncology. In 125 years, we have come a long way in radiotherapy, and the job and role expertise of a medical physicist has expanded hugely. And today, it is not just the physical dose, but it is a biological dose and it is based on the quantitative imaging, biomarkers, new terms like radiogenomics and the genomic guided radiotherapy. We're talking about the image guided radiotherapy. So huge development, and we therefore need to prepare the medical physicist not for today but for. Can you please unmute others? There's a lot of sound. Can you mute yourself? Stephanie Corday, can you mute it yourself? Lot of noise is coming. Yeah. So a lot of things are going. Technology is rapidly changing, and therefore the medical physicist role is very complex, demanding. We need clinically competent medical physicists. Now, few questions to Dr. Subramani, that what do you think the present education and training to cope up the role of medical physicist to be specifically in radiation oncology, the precision radiation oncology you talked about? Are we geared with these things? Do we need to do more in this education and training?
It's a really nice question, sir, because so whatever I talked about, very briefly, it's not anything new, though it is well known to our community. You understand, what kind of the directions we are traveling with, and what is the curriculum today, what we are having basically to address the 4 areas like radiation safety and protection, radiation dosimetry, treatment planning, and technology performance evaluation like a QA and QC. So this is what the major the emphasis on the curriculum what we have today. But if you look at that, the precision oncology where it is directing, or the towards traveling, we need to have not only the radiation dosimetry, we need to have the biology in detail, like a molecular biology, cellular biology, computational biology, system biology. We need to have kind of the genomic, the cancer genomics, cancer immunotherapy. We need to have the knowledge on that artificial intelligence. We need to have the knowledge on mathematical oncology. We need to have the knowledge on preclinical, the small animal research. So there are many, the potential areas. If you look at that in one pie chart, the medical physics now, we need to incorporate almost 50% of what most of the educational institutions are having as a syllabus today. So like artificial intelligence, immunotherapy, there are many things. Only then we will be in a position to really give and make us some solution for the clinical, the problem what we are facing towards the cancer.
Yes, I fully agree with this. Radiobiology, the cancer biology, also the imaging technologies which have come up in a great way, the AI, large data mining, all these topics needs to be added into the curriculum of the Masters in Medical Physics. Now, do you think that what we have 2 years Masters in Medical Physics, and then after that either 1 year residency, some places is 2 years residency, is it enough to accomplish the things and also to become, because such a high-tech, not only in radiotherapy and nuclear medicine, other aspects of the thing research, do you think this period is enough? And if you have to increase, what are your suggestions and how complex it will be?
Again, it is a very important question to be asked and addressed, sir, actually. So if you see that, the kind of the trend what we are actually moving towards is not only in one, therapy, physics, or, imaging. It is integrating or converging, the imaging, therapy, and all other, contemporary, physics or, the related important areas. So in that respect, probably 2 years after the post-graduation is minimum required to have that, the kind of the training program. That is what, most of the countries globally, they have. And then probably very competency-based curriculum and, the clinically oriented, the training program may be, possible to, design to, learn to address kind of required, the education of today's and tomorrow's practice.
Yeah, and now there is in US trained the doctorate in medical physics course, DMP, and now they want that's the thing required. What is your the view regarding specifically to Asia Pacific region, AFOMP region?
That means
the DMP, not only just a master's in medical physics, but doctorate in medical physics.
Yes.
Integrated training program they have started.
Yes, yes, DMP, yes, yeah. Probably, see, after a particular experience of clinically, qualified, the physicist, certainly they will have, kind of a good understanding to carry out that, kind of the innovative research kind of, work. So in that scenario, after a particular period, having some kind of, the examinations, probably, if there is a possibility to have the, the DMP kind of the program in other country also, it will be elevated to the profession, as well as, it is possible to result in kind of a quality work, even the day-to-day practice. So this is what, I was, having some kind of, the idea to have kind of the debate, whether part-time PhD, in-service PhD will result in, diminishing the clinical service or enhancing the, the clinical service. So if you look at that kind of, the debate, obviously that, after obtaining the research or doctoral program, and the enhancement in the clinical also will be reflected. So some kind of, the mechanism wherein that, the qualified and experienced people should be encouraged to do, the kind of the DMP kind of the program in the Asia specific, the context as well. That is what my personal opinion is.
Yeah, and also now because medical physicist job is becoming a very specialized one. It is not that the same medical physicist can be in radiology, nuclear medicine, or radiotherapy, and even in the radiation oncology, you see such a growth has taken place. Do you suggest that there should be some fellowship programs, meaning a particular, like in medical sciences, they have into some procedure or some kind of advanced training, and the fellowships are offered to undergo these things. So the advanced center can take up such kind of curriculum, so that a specialized training, let it be this just the image guided radiotherapy, or maybe radiogenomics and the radiotherapy kind of things should also be initiated.
Certainly, that is what actually it's a very nice program, or the kind of that's what recent the talk by Robert Jarras also has enlightened. We have to learn the lesson from that, the medical practitioner, what actually they are adapting, how they are evolving. So when we wanted to have kind of a highly qualified medical physicist to specializing in a particular area like stereotactic radiosurgery, and the brachytherapy, particle therapy, there should be a fellowship program after a particular period, the having understanding that the basics of what actually we are meant for, then that will enhance certainly the clinical care and the innovative research. That is what my opinion is.
Yeah. So even IAEA document TCS 56 now, which has been revised now, first revision after 2013 has taken place. IOMP has also endorsed it. So we have made some changes and some addition of the topics, but not all the topics what we are talking today are covered, because it becomes then very bulky, very heavy syllabus. Similarly, AFOMP has already constituted a task group, and within this month itself, we will be getting the revised syllabus in two formats. One is a basic to know, and then another is an advanced, wherein all these topics will be there. So that AFOMP is working in this area. So this is a question from Dr. Mary Joan. She's asking, can you please enlighten us about how we can bridge the skill gap to sustain at the same time supporting ourselves?
Okay, so I think it's very important to address this question. So when you look at that, the Eastern Physics Committee, they have, defined or, given that guidelines, what are the grand challenges facing medical physics and radiation oncology. So that may be of context of, the European scenario. When it comes to that, the Asia specific or, the country like in India, probably there is a great challenge is, having that basic infrastructure and that, the structured or, accredited program wherein, the proper, the manpower or, the facilities and faculties to impart that education, and also that, kind of environment is very much important to fill the gap between the skill, what is required, and what we are supposed to actually, or what we are having, a certain point of, the professional time. So what I mean to say that, the infrastructure, environment, and, the curriculum, and, kind of the training program, these are all important things to fill the gap of, the skill development. That is what, in my opinion.
Yeah, even recently, the published paper from the survey of the AFOMP, where special groups should be formed to encourage and interact the young medical physicists, the seniors and things, how to catch up with the new development, new this thing training, the special interest groups, and that should be adapted into our region also, I think. We had a very good talk, very good interaction, and also the every NMOs, every the authorities should take up the step to revise their curriculum, to train the medical physicists, not just for today, but tomorrow. So once again, I thank Dr. Subramani for excellent talk on the role of medical physicist into the precision medicine. And the AFOMP school is actually the CPD accredited, and 2 points for this 1 hour webinar are allotted with the certificate. Already the chair of the PDC has, Professor Chai Hong, has put the link on this chat box. So people who want, the participant who want the certificate of attendance and CPD, these things, please provide your data so that the certificate is given. Also, I'm very happy that our AFOMP school webinars are also now CPD endorsed, and thanks to ACP SEM for endorsing our AFOMP schools. Already AFOMP webinars have been endorsed, and these schools per hour, they are about 2.5 to 3 hours, so we'll get 5 to 6 CPD points and certification. So in this series of the AFOMP school webinar, which started in June 2021, so this is actually the 7th webinar and the 2nd webinar, AFOMP school webinar of 2022. This will be on 26th February 2022 from 6:30 a.m. GMT to 9:30 a.m. GMT, and this will be medical physics and nuclear medicine physics and beyond, and there will be 4 speakers, eminent speaker. They will be speaking on different aspects of the nuclear medicine and the role of medical physicist into that thing. The entire information is available on the AFOMP website. You can register, attend, and then if you need certificate and CPD points, you will get. Again, regular AFOMP, the monthly webinar, which used to generally hold every Thursday, but now we have started it on Friday because of some demand. But if still you think that it should be gone back to Thursday only, please let us know. 4th March, we have the AFOMP webinar, and this will be on regional clinical training for medical physics in challenging or changing world. And that is in continuation of this today's AFOMP webinar. You can say that how regional cooperation clinical training they are there, and this will be by Donald Macklin, who has served for many years to the IAEA and expert into the regional cooperation, and Anne Perksin. This will be there. As you very well know that the AFOMP IAOCMP will be held during December 10 to 12 at Taipei in Taiwan, and the website is already on. You can get information, and the theme is Adapt to Change, Explore Together. Again, the triennial, the IUPASM, that is a World Congress of Medical Physics and Biomedical Engineering, is being held at Singapore during 12th to 17th June 2022 in a hybrid mode. If you can attend in person, you are welcome. If not, you can attend virtually. So these are the information for you. Many awards we have started. New award for a PhD in radiobiology is coming up this year. So please try to go to the AFOMP website for additional information, and a lot of activities and information they are available. In addition to this AFOMP school, a special AFOMP school is being arranged on 19th March, and Professor Robert Gerard, I had a long discussions with him, and his colleagues will be presenting the possibilities, the avenues in furthering your medical physics education, research, training, possibilities from AAPM to collaborate. So that information within a week I will put on AFOMP website. With this word, I thank Dr. Subramani for an excellent talk and overview from just the physical dose to a biological, and how the precision radiation oncology needs the competency of medical physics, the radiogenomics, the radiomics, and the AI, and all those things. Thanks to Professor Chai Hong for coordinating. Thanks to Dr. Jin Xians, the chair of the ETC, for arranging all this Zoom links and things. Thanks to Dr. Rajni Verma for coordinating, the circulating the information, and coordinating with all of us recording. The recording of this talk will be available on the AFOMP website within 48 hours. You have missed it, or people have missed it, or want to listen it again, you are welcome to do that thing. With this word, again, I thank, and let me see there are any other questions. There are appreciations to Dr. Subramani from many you might be seeing into the chat box. So with these words, Dr. Rajni, do you want to add to anything if you want? You don't know. So these are a lot of activities we are doing. See, to be we have to active, because the medical physics is not a stagnant one. It is developing. It is with a rocket speed. It is going to be able to catch up all those things, and you have to be very active, participating, grab the knowledge, possibilities, they are coming to you. So with these things, Rajni, do you want to add anything, or we can close it now? Okay, then I thank each one of you, all the participants, and directly, indirectly, people who are helping us to make this webinars successful. Thanks one again. Have a nice time, and then we look forward for your participation on 26th of February for the AFOMP school. Thanks again. Bye. Bye. Bye.
Thank you, sir. Thank you, everyone.
Bye.